We'll get started in just gonna let a few more people in. Just a couple quick announcements while we're letting people in. Please note that for today's webinar, your microphones are muted, but feel free to use the chat function for any questions that you may have throughout our session today. Please also note that today's webinar recording and presentation will be distributed via email to all attendees after the webinar has concluded within 1 to 2 business days, probably by the end of this week. We'll give another couple seconds to let the last couple people joining us come in, and then we'll get started. All right. Well, welcome everyone to today's On My Mind webinar hosted by the My Mind Collaborative Quality Initiative. We're absolutely thrilled that you were able to join us on this wonderful December day. My name is Jason Robertson, and I will be your host for today's session. First thing that we just wanted to go through real quick is on our CMEs. We'd like to announce that today's webinar is approved for 1 CME CEU credit. On your screen, you'll see the code and telephone number to text to receive that credit. You'll have 24 hours from the conclusion of the webinar today to text that unique code. The details for the CME CEU credit are in your meeting invite as well for you to reference, and it will also be displayed on screen at the conclusion of the webinar today. Just a quick disclaimer before we get started. The views and opinions expressed in this webinar are those of the speaker and/or speakers and do not necessarily reflect the views of Blue Cross Blue Shield of Michigan or of Henry Ford Health. With that, I'd like to introduce our speaker for today. It's my absolute and distinct pleasure to introduce you to Dr. Doree Ann Espiritu. Dr. Espiritu leads the Behavioral Health Integration with Primary Care Initiative and provides outpatient care for adult and geriatric patients. Board certified in adult and geriatric psychiatry, she was trained by the pioneers of perfect depression care and the Henry Ford Zero Suicide Initiative, and is a committed advocate for suicide prevention. Her expertise has earned numerous honors, including the Henry Ford Health System Shadow of the Leader Award, the Dr. Joseph Ponca Caring Physician of the Year Award, and consistent recognition as an Our Detroit top doc in psychiatry. Today, she'll be speaking on caring for the caregivers of patients with dementia. In this presentation, she'll be highlighting the unique challenges faced by those supporting individuals with cognitive decline. She will emphasize the emotional, physical, and psychological toll caregiving can take, which often leads to caregiver burnout, depression, and social isolation. The presentation will explore evidence-based strategies to support caregivers, including psychoeducation, respite care, and integration of collaborative care models. Today, we'll plan for about 45 minutes for the presentation, followed by 15 minutes for questions and discussion. Please feel free to submit your questions as we go through the presentation today, and Sarah, who's joining us from our team, will be sure to monitor those comments, and she will pipe in every once in a while with a question here or there for Dr. Espiritu, or you can feel free to hold your questions to the end and we can address those during the Q&A. Before we begin, just the last couple quick reminders, all participant microphones are muted today. Please use the chat to submit any questions you have during the presentation. And with that, Dr. Espiritu, let's get started.
Hey, thank you, Jason. Good noon, everyone. Thank you so much for giving up your lunch hour in order to participate in one of the On My Mind webinars. Today, my topic is caring for the caregivers of patients with dementia, easing the burden. As I worked with Jason and Sarah and the rest of the My Mind team on this topic, it was by chance that it was scheduled in December. And how appropriate it is. As we are in the holiday season, everything gets very hectic. Our tasks quadruple during the holidays, and we are excited about, putting the trees, like Veronica has her tree up, and buying presents. But caregiving does not take a break, even more so during the holidays. How appropriate then that we are discussing this topic on easing caregiving burdens and reminding us that we can take care of others only when we need to put our masks on first. So today we are going to define the role and the challenges of caregivers, recognize the signs and symptoms of caregiver distress, and review the evidence-based strategies to support caregiver well-being. But also, this is not objective and just a goal, because we cannot fully talk about caregiver distress if we do not talk about dementia. I know dementia is a big topic in itself, or topics, but I also believe that a review about the concepts of dementia is important in any type of talk on caregiver burden. As you will see later, dementia is the most common disease that requires years and years and years of caregiving. So this is a slide from the 2025 edition of Caregiving in the United States. It was recently released by AARP and the National Alliance for Caregiving. It's a lot of information. So the report reveals a rapidly evolving caregiving landscape. It now includes 63 million Americans who are family caregivers, a nearly 50% increase since 2015, where there were only 20 million caregivers. The surge underscores the growing demand for a family of caregivers who provide essential support to those with chronic, disabling, or serious health conditions. I will mention a few findings. In terms of demographics, 1 in 4 adults is a caregiver. So just imagine how many participants there are now. There's 117 easily, right? I'm not good in math, but 100 divided by 4, right? That's how many caregivers just in this group who are also caregiving for loved ones, caregiving for patients who have dementia, and caregiving for patients. One of these, 94% care for adults, and 1 in 3 is under age 50. So caregivers are increasingly diverse also across race, income, and generation. The other thing, as you can see on the bottom or the middle part, is that 29% are sandwich generation caregivers, meaning they are supporting both their children, spouses, and adults. In terms of the intensity and complexity, over 40% of caregivers now provide high intensity care. So it's not just the basic ADLs, bathing and, driving them to doctors. It's performing complex tasks like administering medications, injections, managing the equipment, whether it's CPAP or, sometimes even catheters. Yet only 22% of them receive training. That's a very heavy burden. The report also outlines key policy areas such as financial support, workplace protections. I wish we could all give all of these important information today, but there's also a roadmap in this caregiving report to build a more supportive system for family caregivers, because they really form the backbone now of long-term care in the United States. There is also a second report which shows the differences between states, and in terms of who gets paid as a caregiver, unpaid leave, respite care, and other factors, because they have very significant impact on the experiences of family caregivers. So for example, in Iowa, about 10% of family caregivers receive pay, primarily through Medicaid, compared to 28% in New Jersey. In Georgia, 59% of caregivers report experiencing financial strain, 35% in Minnesota. In Michigan, 88% are unpaid. And there's 1 in 5 caregivers who are caring for someone who has an Alzheimer's disease or other form of dementia. So I mentioned earlier, I'm going to talk about dementia because, as you know, this is the major disease that caregivers are involved in. Dementia is a collective term used to describe the neurodegenerative disorders of the brain that affect cognition. So a frequent question of patients and caregivers usually is, what is the difference between Alzheimer's disease and dementia, right? And so we always say, dementia is an umbrella term for all types of forgetfulness that happens after 65 years old, although we know also that there are several, there's also a small amount of patients who develop dementia earlier in their lives. Alzheimer's disease is the most common cause, the most frequent. It is estimated about more than 55 million in the world have dementia. Alzheimer's disease affects 7.2 million Americans, and it commonly occurs in older adults, but it also happens in younger ones. So the current spectrum of dementia, as you see in this slide, is changing. As more is learned about the family of these disorders, so in the not too distant past, we thought that Alzheimer's disease in the segment of the pie would have been the largest portion by far. But we're seeing that there's actually almost like equivalent of mixed dementia and Alzheimer's disease. And then dementia with Lewy bodies is also gaining recognition with a proportional incidence of 8% of all dementias. So Lewy body disease, a lot of you would know, it doesn't really present with memory problems initially. So it comes with motor symptoms. They think it's Parkinson's disease. The patient gets prescribed amantadine or Sinemet. They pass out, they get more agitated, they have very idiosyncratic reactions to medications. And then that's when the other types of examinations and evaluations happen. Frontotemporal dementia, while it's not a lot of patients that we see, it is one of the very difficult types of dementia because patients are very agitated, very disinhibited, and they can be involved in some troublesome activities that are not likely their character. So that's also a very, very difficult type of dementia. When we think of dementia, we also need to think about the other neurocognitive disorders that are happening that we don't, that we also are going to be involved in taking care of. So one of them is early stage diagnosis. That is patients in their mid-40s who have a genetic predisposition for rapidly degenerative disease, dementia. And again, by the time they reach 60, they are so far gone into their cognitive impairment that they no longer know their families. Most of them will already be in a facility. And then there's the other cognitive impairments in traumatic brain injuries, in strokes, where, it happens earlier in life and then you end up taking care of them. And as you saw earlier, the pie graph of the ABCs of dementia. So, as I mentioned earlier, Alzheimer's disease is the most common dementia, and it's the 7th leading cause of death, and the only cause of death in the top 10 diseases in America that cannot be prevented or cured. I know it's depressing, but there's a lot of other medications and a lot of tests and a lot of other biomarkers that are being seen, but it can't happen so fast enough, right? There's 7.2 million Americans with Alzheimer's disease. And by 2050, an estimated 11 to 16 million will have dementia. Very costly. And in Michigan, there's 202,800 people. As I said, there's no cure. The next slide. Sarah, are you responding to the chats? Because there's questions popping up. Okay. I just wanted to make sure. Okay. So in terms of the other facts on dementia, about 2/3 of Americans with Alzheimer's disease are women. 1 in 3 seniors dies of Alzheimer's disease or another dementia. And this is really staggering as well, right? How can we prepare if we are not told, if we carry so much stigma about saying that your loved one is being diagnosed with dementia? Only 45% of people are told of the diagnosis. A lot of us are in denial, not just the family caregivers, but also us health caregivers. You compare it to the 90% of people with cancer who are told the diagnosis. Every 65 seconds, someone in the United States develops dementia. So this is where we start in terms of the caregiver talk. 83% of help provided to older adults in the U.S. comes from unpaid family caregivers. Family caregivers provide 18.5 billion hours. So where are we spending all these healthcare dollars in? They're spent in many more other initiatives, yet there's 233.9 billion cost that is spent on providers alone. 2/3 are women. And the duration can be 10 years. And like I mentioned earlier, 1/4 are sandwich generation. What makes it very difficult is that it's more than just memory loss. It's loss of the personality, loss of language, and visual perception. Someone who has been the rock of the family all of a sudden becomes apathetic, sits in the corner and doesn't say anything. Family is waiting for him to make decisions, and they can no longer make these major decisions for the family. The neuropsychiatric symptoms of dementia are actually the major symptoms. If you think about it, the very first patient, August D., who was diagnosed with Alzheimer's disease, right, was already delusional by the time she was in the hospital in Frankfurt. So, it is a mental health disorder, no question about it. Yet, I was talking to Sarah and Heather and Jason today. I just saw a patient today who was brought to the emergency department and discharged. This patient was already so agitated, and there was a lot of safety concerns, yet there was no psychiatric consult. So these are the things that we get faced with because dementia now is more than just a memory problem. So we have many different ways in terms of how to categorize stages of dementia. One of them is to think about the 10-year course. You divide it into 3, right? In the early stages, the middle, or the moderate, and the late. By the time you see a patient in your clinic, the patient is probably already in the late mild to early moderate, right? Because again, that is one part where we all say, oh, we're just forgetful. Oh, that's part of aging. Oh, I forget my keys too. I sometimes get lost in familiar places. Well, it's dark. I mean, we have all these excuses. And so we don't really get to let primary care say, can you just start evaluating my mother? Because one day she went to Ace Hardware, and that's a real example. She got there, she sat down and said, I don't know where I am. Thankfully, all the staff in that store know her because she's in the neighborhood. So by that time, the patient is already in the moderate to late mild to moderate stage. So they repeat things. They can be confused at times, but again, who doesn't get confused at times? And then in the middle stages, they may start to wander and pace. They become more impatient and restless. They become suspicious of others. And this is where moderate stage is where there's the time when there's the most neuropsychiatric symptoms. They have the, delusions about infidelity, which is very, very damaging to relationships. They resist being helped and become more aggressive towards others. So this is where psychiatry is usually now called and get involved. And in the late stages, they lose the control over bladder and bowel. And this is the only time, and this is the most common reason why we decide for change in facility, why we decide to do long-term care. But again, all the planning should start much earlier on in the disease. I'm not going to belabor this slide. It's just showing the different other stages and then the way you can approach patients in terms of communicating with these, in terms of communicating during these different stages. So going on to caregiving. Family caregivers, like we said earlier, provide essential support to loved ones. And they provide extraordinary care. It's usually beyond just family relationships. It involves significant expenditures of time and energy, and tasks that can be unpleasant, uncomfortable, and psychologically stressful, exhausting. And if you think about the dynamics that happen, when there was not a good foundation in terms of the relationships among the family, and now they are forced to care for someone who abused them or someone who didn't really pay attention to them when they were little. Now, all these dynamics come about. So, no one is born knowing how to be a caregiver. The belief that often leads to caregiver guilt. Asking for help and seeking resources is not one that is your first step when you're trying to care for a loved one and you're so committed to doing that. Caregivers and the long goodbye. Since family members are the core of the long-term care network and are unpaid and unrecognized, mostly female, everything suffers. Everyone suffers. The ambiguous losses. The many caregivers report that the main problem is not really the illness, but the ambiguity and the uncertainty it causes. So now you don't really know when, right? Sometimes they're asleep all day, everything is okay. If all of a sudden they don't know you, you don't know what to do. If patients get delirious and agitated, you call your primary care doctor or bring them to the ED and they're given Haldol. They quiet down when they're at the ED, brought home, and the cycle continues. Dementia causes unpredictable memory losses that comes and goes. It's really a roller coaster ride. There's ambiguous feelings, like I mentioned earlier, in terms of what has happened when they were children, the abuse, the other things that could have impacted on the relationships. There's sadness experienced for caring for someone who is here physically, but not emotionally. And we say, unfortunately, it's double death. The mind goes first, but the body is still here. So how do you even approach that? And then the living losses have no closure. Ceremony like finite losses and death. How can you continue to discuss planning with someone who doesn't have the words? What then do you do? This is just another schematic in terms of the interplay between emotional, social, physical, and financial stressors related to caring for someone with dementia. Emotionally, I never envisioned my future like this. A lot of caregiver distress, a lot of those caregivers who develop depression actually were not willing or volunteer family caregivers. They were just put in a position without any choice. Socially, friends are so uncomfortable. Then you isolate and you get depressed. Both the caregiver and the patient are both now, in one, apartment where it's just them. And sometimes the caregiver abuse gets reported to Adult Protective Services is not really abuse. Sometimes it is a patient who is a loved one who has dementia who gets agitated. The caregiver tries to hold on to them. They both fall. One of them gets bruised. One of them gets to the ED. Next thing you know, Adult Protective Services is being called. And then the physical, the difficulty of lifting, not knowing how to get them out of bed. There's even more safety concerns there. And financially, we could go on about, how much burden of financial problems there is for the patients. Don't get covered by Medicare. Oh, it's just Medicaid. Oh, Medicaid, it will provide for long-term care, but not Medicare. I mean, it's just the confusion, mayhem that happens. And it's on us again, health caregivers who are also caring and thinking about all these issues. So in as much as there's so much love, laughter, and joy and pleasure in giving a loved one all the care that they need and keeping them at home, eventually there comes the helplessness, the embarrassment, the guilt that you're not doing the best that you can, or that you're giving up on your loved one, right? And as much as you can try to learn about the disease or diseases, you yourself are not able to keep up with your own medical issues. So now you're also getting unhealthy. Guilt, regret, and even grief, or worse, suicidal thoughts and homicidal thoughts sometimes. Hopefully that doesn't get to that point. So what should we be paying attention to? I, as a physician, would always turn to the other patient, not really my patients, but they're the family caregivers, and ask, so how are you? And my office here at Columbus, and this is always like I feel is a family meeting area, because this is where there's a lot of these dynamics that happen. Look at the symptoms of caregiver distress: feeling overwhelmed, worried, sad, or irritated, sleeping too much, too little, fatigue. If the loved one doesn't sleep, the caregiver doesn't sleep. You give the loved one trazodone, everyone is happy because they have 4 to 6 hours of sleep, hopefully. There's changes in appetite. But what are these symptoms? These are symptoms of depression. Excessive use of alcohol, drugs can happen, frequently falling sick. And as you can see, in your My Chart, you will be getting more and more My Chart messages from the loved one telling you about other things that are happening. Sometimes that's not the patient's issues, but it's their issues. And then they struggle with the suicidal thoughts or homicidal thoughts towards the person being cared for. I think this is just a summary slide that 70% of patients of Alzheimer's disease live at home. Someone is getting kicked out, Sarah, so it's showing up. So hopefully they'll be able to come back. In terms of depression and suicide in caregivers, and thank you, Sarah, for reminding me to, also focus on this, because there is not really a lot known about suicide specifically among caregivers. But there is a small but very meaningful body of evidence on suicidality in family caregivers. They provide consistent evidence of suicidal ideation, suicide attempts, and deaths by suicide across, a very diverse range of caregivers. But much of the literature focuses on suicidal ideations. Articles show that out of the 70% of caregivers who grapple with their own mental health issues, about 33% have seriously considered suicide in the last 30 days. And in the caregivers aged between 24 to 43, the rate is closer to 45%. So some of the risk factors for suicidal ideation identified in some of the reviews of literature are consistent with those that are seen in general population, right? Depression, anxiety, dysfunctional coping strategies. But there are things that are very caregiver specific that are not being asked, like dissatisfaction with a caregiver role or conflict over care provision. Imagine that. 7 children, each have different decisions about how to approach end-of-life issues. These are very unique questions for caregivers. And also this has implications, obviously, for the use of existing risk assessments like Columbia or PHQ-9. They do not capture the risk factors that are specific to the caring role. They're not designed for that. That's another issue, the dyadic nature of the caregiving, especially if we need to safeguard the vulnerable care recipient if a caregiver is suicidal and homicidal. I mean, a lot of these issues are brought up, but I don't think we are even ready to open the can of worms. Some studies also identified suicidal ideation in caregivers without mental illness. So the implications is that we need to assess all the caregivers, not just the caregivers who have depression and anxiety. We need to assess for suicidal risk, not just those with depression and anxiety, but all of them. We need to consider the cultural traditions and family dynamics, and create safe spaces for caregivers to discuss the thoughts of suicide the way that we've been talking about in my mind. So, we talk about self-care and stress reduction. Easier said than done. These are always very generic, right? identifying the positive aspects of caregiving, understanding the impacts of thoughts on the mood and behavior, learning relaxation skills that can apply to, you know, all the things that we do, identify support and ask for help. Um, Caring for yourself includes also taking time out, avoiding isolation, but the counseling piece is what I would like to emphasize. That sometimes, having a massage can be good, but 5, 6 years later, your blood pressure is out of control as a caregiver, your blood sugars are out of control, your body's telling you you need to do something else. You need to go for therapy. You need to seek mental health treatment. Support groups is good. It's easy to access them online, but sometimes sitting down and telling your primary care doctor, I too need help. Please can refer me to behavioral health integration or behavioral health services or pastoral care, whoever you feel is the one that can help you the most. That would be the best way to take care of yourself. Providing real world case scenarios to caregivers and discussing what to do in a crisis. I think, again, we always think that takes a lot of time, but just giving examples in psychiatry, it's sometimes difficult to share some of the experiences that you see in your own family life, but sometimes that's very helpful and very validating for caregivers. Be creative. Humor is always a really good approach in terms of patients with dementia. Travel guidelines for people with dementia. Sometimes some family members plan on switching all year. 3 months here in Michigan, 3 months in Florida, 3 months in South Carolina or California. But sometimes that makes the behaviors even worse. Patients are even more confused the more you change surroundings. Cultivate the understanding of the disease beyond the clinical aspects. Again, the mental health and the psychological ways that other members in the family are affected. We need to educate the caregivers on the disease progression. I showed you earlier in terms of how you would, think about the 10-year course, dividing it into 3 stages. This one is always a big deal, in terms of why a patient gets delirious, why there is a significant change in a patient who has dementia, the risk of infection due to disease progression. It doesn't even need to be a major, bacterial infection. Sometimes a common cold can, trigger. The X-ray that we consider in geriatric psychiatry and geriatrics is the urinalysis, because that's the most common reason why patients get agitated in patients who have dementia. We need to discuss the treatment options for the end-stage dementia, which sometimes we think that we're already in the moderate stage when all the medical and psychological and neuropsychiatric problems are happening. We're already so spent that we don't even have time anymore to think about the latter stage. So these are the things that need to be incorporated and baked into the treatment planning. We need to discuss the importance of advanced planning, dementia or not, right? This is always something that we should be doing anyways. Disease progression, institutionalization, funeral arrangements. We have time. Okay. So just a few key takeaways. Caregivers are essential partners in healthcare. Supporting caregivers is essential for their well-being and the quality of care they provide and the quality of life for the patients. We need to be proactive in terms of supporting them, educating them, and resources, giving them resources who can mitigate caregiver burden. Wanted to end with this quote from Lauren Kessler. Whatever it is you give, and you give a lot, you give until you think you give no more. You get back even more. If you allow yourself to live the experience rather than fight it, you yourself can be nurtured as you nurture. There is the deep satisfaction that comes from staying connected to a loved one. So there are many resources from the American Psychiatric Foundation. I'm sure a lot of you probably have these already. Family Caregiver Alliance, Caregiver Action Network, all of these other things will be provided for you. And I'm so lucky, we are so lucky because we're able to end before the time, and we're able to give Veronica Bilicki a chance to be able to talk about the CARE, C-A-R-E, that we have here at Henry Ford. So Veronica is the manager of the CARE program. She's also the I think the senior navigator program and the president of I Care for You, right? If we can just give Veronica a chance to give us a little bit of overview about our care program here at Henry Ford. Please take it over.
Thank you so much, and I appreciate you having me. Your presentation was great, and I really enjoyed all of the caregiver wellness and tips on supporting the family caregivers who are taking care of these patients. Like you've said, oftentimes caregiving comes, unexpectedly to us. And it's just, one day we're the daughter, we're the son, we're the neighbor, we're the friend. And the next day we're the caregiver, and we don't even realize that. And all of a sudden we've got this burden or stressors, additional stressors that are put upon us. And so what I wanted to just say is just let you know that at Henry Ford Health, we have the Caregiver Assistance Resources and Education Program. We are going into our 10th year of existence. We were started back when Nancy Schlichting was our CEO. She was a caregiver for her father, and realized that we needed to be able to support these caregivers of our patients and also our patients who are caregivers. Our mission is to assist these family caregivers in identifying resources within their community that support their mental, physical, and social well-being. And this includes access to all these experts that we have here to offer at Henry Ford Health. We have support groups, educational classes, one-on-one guidance, and self-care, many different self-care opportunities. There are, for those of you who work at Henry Ford who are on the call, there is actually an EPIC referral. REF 315 is the number that you can actually refer to the CARE program. All of our services are supportive services, so we're not billing insurance. We're not billing the patients or the caregivers. Everything we offer is free and open to the community as well. So those of us who are not part of the Henry Ford Health System, you can find us on henryford.com. And all of our classes and support groups and one-on-one services that we offer are free and open to the community as well. We do have virtual support groups every Tuesday at 11 that we offer with our social worker, who is our care specialist. His name is Carl Frazier. He's been a social worker within our health system for many years, and he does a great job. We also have 2 monthly in-person support groups. One of them is in Allen Park and one is in Sterling Heights, and those are offered monthly. And then we have an art therapist. Her name is Kelly Dark. She's wonderful, and she does creative mindfulness with art sessions most Thursdays at 10 and 6. We also offer all about advanced care planning. One of the stressors caregivers can eliminate is kind of preparing for themselves. And also their loved one. And they can do this by preparing their advance directive and medical durable power of attorney. So we actually explain how to fill out that document, knowing that you do not need to go to a lawyer to fill out this piece of information. It doesn't need to be notarized. You just need 2 witnesses for it to be a legal document in the state of Michigan. And so we can walk you through that document as well. We do partner with the Alzheimer's Association of Michigan and monthly offer dementia and Alzheimer's related educational classes on a Monday. And then we do any kind of custom support for churches and community organizations. We have, kind of a bank of classes that we offer in addition to what's here, things on resilience, on how to maintain friendships, reduce caregiver stress, and things like that. Everything can be found online on henryford.com/family caregivers. And, like I said, it's open, it's available to the community, and there's no charge. We have a contact form, not only in Epic, but also in online, where you can reach out to us, and it goes directly to an email that Carl and myself answer. And we will get back with you, usually within 48 hours, sometimes 72 hours, and help walk you through what is stressing you as a caregiver and what kind of information we have available for you, what's out there in the community, and kind of help you self-identify as a caregiver, what really is going on behind the scenes and what is stressing you out and getting you pointed in the right direction. We're not here to solve the problem for you. We're here to work with you and walk hand in hand. We are well connected with behavioral health sciences, our employee EAP and employee wellness teams here at Henry Ford. And again, with all those different community resources that are available, such as the Alzheimer's Association and different supportive agencies in the community. If you don't need to talk with someone or you're not ready for a class, there's a blog that Kelly Dark does on our website that's free. Each blog takes less than 5 minutes to read. You can do some self-care that way. For those of you who are being overwhelmed by paper and things like that, you can print our caregiver binder inserts. So say, for example, you needed to track blood pressure readings or blood glucose readings or steps or medications or your supportive team that you've put together to kind of help you. You can find that online, and you don't have to recreate the reel. Those are available for everyone. And then this, the last page here, is all of our information. We have a toll-free number that goes directly to Carl and myself that we answer. You can leave a voice message and we will get back with you. We have a Facebook page as well, a Facebook group. It's Henry Ford Health CARE program on Facebook, and it's a great way to see information and also get supportive resources and find that kind of caregiver support group that you might need. And then if you are in need of support immediately, because we're not here 24/7, unfortunately, we don't have the bandwidth for that, but you can text TOUGH to 741-741, and that is a free 24/7 crisis counseling from Rosalind Carter Institute, specifically for caregivers of all types. In addition to that, I'm sure many of you on the call are also aware that the Alzheimer's Association has their toll-free number as well, that you can access 24/7 if you are experiencing some difficulty with your loved one who's experiencing dementia or Alzheimer's. And so that's all I have for you. And I, again, appreciate you having me here. And the slides are available afterwards. They will be sent to everyone. Thank you.
Thank you. Thank you so much, Veronica.
Excellent. Yeah, thank you both, to Dr. Espiritu and to Veronica, for sharing amazing resources with us today. I know everyone on the call is really excited to utilize those and put some stuff into practice. Just really wonderful to know that we have community programs that are not just for a certain group of people, but open to all. So thank you so much, Veronica, for sharing that with us today. We really appreciate that as a group. And of course, a special thanks to Dr. Espiritu for her presentation as well. Lots of wonderful information. We'll now move into our Q&A portion of our webinar, where you guys can ask any questions to Dr. Espiritu or to Veronica. We have about 10 minutes for Q&A this afternoon. So with that, I'll dig in. Sarah is so kindly going to be watching our chat for some questions coming in. So feel free to overwhelm the chat with your questions.
Thank you,
And,
Jason.
you know, in case we're not able to answer all questions, you know, Sarah, my mind team will have the emails. I'm sorry, I wasn't able to put my email here, but yeah. Go ahead.
Thank you so much, Dr. Espiritu and Veronica. That was an amazing talk and lots of good resources. Somebody did ask in the Q&A, either Dr. Espiritu or Veronica, if you could put the EPIC referral number or code in. Thank you. You've seen it too. Awesome. So we had that as a question. Lots of thank yous, lots of people who this is personal to, and they appreciate this information and resources. What a great presentation, very informative and helpful. Lots of those coming in. Other than that, it looks like mostly just CME and CEU kind of questions. So I wanted to ask Dr. Espiritu, I know in our discussion, we talked about how there are some risk factors for this population as caregivers, but also some protective factors that like family responsibility. How might you have those brief conversations with caregivers when you have the chance to?
Yeah. So like I said earlier, you know, turning to the other one in the room is a great big step, but you need to put time also. You know, it can't just be when you're getting the patient in the waiting room and just saying, "Hi, how are you doing? Okay, I'll bring back your loved one after my evaluation." You know, those are not enough interventions, right? So when you see them, like the caregiver distress symptoms, you really want to bring that up, and you know, sometimes it's just a matter of asking, are you going to be okay? Are you okay going home today? I mean, just be very present and say, you know, if you need us, this is my number. But if you want to talk to your primary care doctor, this is, you know, how we can start the process for you. And obviously all the other, you know, 988 and all those. But a lot of caregivers actually are yearning to be heard and yearning for help. So, you know, you'll never err when you ask how they're doing. It's always a great big step. So
just opening it up for them to be able to talk about their experience and vent and let you know what kind of resources they're interested in.
yeah.
Would be helpful. Okay. Thank you. We had a question come in. It says, have you had much experience with the new infusion agents for Alzheimer's? Like Kisunla.
Yeah, so majority of the infusion agents are done through neurology and very early into the, you know, enrollment process. The difficulty in terms of referring for the infusion agents is that you have to identify them at the mild cognitive stage. And as I mentioned earlier, by the time they get to us, they're already in the moderate to severe. So really, like when they're 70s and they start, you know, showing some symptoms, then that's when you start to talk to your primary care or neurologist, like, you know, these are things that I've been noticing. Let's do a MOCA, let's say, or a mini mental status exam, or just, you know, some basic screening questions, and then maybe refer them for infusion. Unfortunately, it's not as commonly used yet. I think there's also questions about biomarkers, which is almost the same. You know, you would hope that all these advancements are, you know, could be used without a lot of expense. But unfortunately, they're still not covered by insurance. A lot of it is still out-of-pocket cost, unless it's really indicated.
Yeah, so that was actually same person that asked that question. So they're on a trajectory, and I think your information is helpful.
Yeah, all exciting stuff, right?
Yeah, we're on the cutting edge. Thanks.
Yes, yeah.
Speaking of that, are there growing resources for short-term respite care? Somebody asked.
I don't know if they're growing, but there's respite places. And I found it difficult also to convince family caregivers, you're getting burnt out. Let's consider respite. And again, it's that whole feeling like I'm giving up on my loved one. I can't go on vacation. I can't be enjoying and he's staying around, in a respite place. They don't know him. I could go on and on. And again, in terms of the ways and how we prevent others to help. And sometimes that's really the only way that you could be able to enjoy more things with your loved one if you're able to bring in more help and resources and respite and all those other things.
And that's kind of good timing, as we had a question come in from Danielle. And she asked, I've noticed many of my patients that are caregivers end up carrying most of the responsibility themselves when siblings aren't able to help or not wanting to. Given this, what advice do you have, Dr. Espiritu, for someone in that situation? And how do you decide when it's time to consider a long-term care facility or that respite care, those kinds of things? So kind of a two-part question.
Yeah, so in terms of the family dynamics, right? I mentioned earlier, like everyone loves their dad. For example, the dad is the one who has dementia, but only one is here in Michigan, for example. So what do you do then? Well, look at what we're doing. We're doing virtual. We have apps where you can enroll all of the other family caregivers so that they can all be part of that network, your own team, in terms of how to involve them in care. Be very specific. I can only do this. Take my dad to appointments, do the meds. Somebody else is to help me with this. If there's too many and the dynamics is like, oh, I want that to stay home, I want that to be I want that to go to hospice, then have a family meeting. Be specific in terms of who is the spokesperson, right? Because, not a lot become legal guardians or durable power of attorney. So it's always to, put the dynamics aside, all the other things that have happened in the past and focus on the now. But again, that's easier said than done. And we always say, decide with your mind and your heart. What did your dad, your mom tell you in the past? What do they want to do when they get to this point? I think those are conversations that always have to, be done earlier on in our lives, dementia or not. So.
And that's a great way to honor their memory as well. We had one last question. If you have any input for the last, 30 seconds or so here. We have somebody on the call whose mother has hallucinations and sees people that have passed that they know and strangers, and wanting to know what is the best way to respond to this. They said, I've been told to go with it. It's not always easy.
Yeah. Well, one of the things I forgot to say is, they don't resist if you don't insist. So mom says, I'm seeing my mom and my sisters who are now deceased, right? But they don't know that. So it's either you say something like, let's see what's on TV right now, or let's listen to some music. If that doesn't work, and it continues, again, empathize, and validate how nice mom was, or how the sister was such a, giving and put in humor. But saying that they're not here, they're already deceased, is just gonna make things even more, make things escalate, right? So I think it's a very different type of psychosis for patients who are confused compared to schizophrenia. So, you know, again, it's always trying to incorporate stories, incorporate humor, before you actually think about medicating them or bringing them to the psychiatrist.
Thank you for that, Dr. Espiritu. All right, I'll let Jason close us up here, and thank you
Yeah,
so
thank
much,
you so
guys.
much. We again super appreciate you joining us today, Dr. Spiritu. I know just from looking at the chat that so many people got little nuggets here and there throughout the presentation that they're going to take home and use and practice. So we really appreciate everything you've given us today.
Thank
Just a
you.
quick reminder before we wrap up about CME CEU credit. Today's code is on the screen. So to receive credit for the session today, please text the code to the phone number provided. You will have 24 hours to claim your credit. So please try to do that before tomorrow at 1 p.m. And if you need any additional instructions, there were some of you that had some questions about that earlier in the chat. Here are those instructions for people who are new to the CME process. This is specific to us at Henry Ford. So if you are a non-Henry Ford employee, you will have to do this process to set that up. Or if you're a new Henry Ford employee, this is your first webinar, you also have to set that up as well. But we hope you'll text that code 88003 to the number on the screen so you guys get all of your credit today. And with that, on behalf of the MyMind team, we want to thank you again, Dr. Spiritu and Veronica, for joining us today and sharing your expertise. And we want to thank especially everyone who joined us today. We know you guys have many things going on in your lives, and we appreciate you coming to learn with us this afternoon. Please note that today's recording and presentation will be distributed via email to all attendees, so look for that in your email. We have a couple bonus flyers and a few things that Veronica gave us as well that we'll be sharing. And finally, your participation certificates will email to you in the next week or so. So look forward to those for all of you who attended today. And with that, thank you very much. Enjoy your holidays. And we look forward to seeing you next year for our next webinar, which is on January 22nd. That is with Larry Heron, who will be presenting on men, masculinity, and suicide and what clinicians need to know. Happy holidays, and we'll see you next year, guys.
Thank you, everyone. Bye.